Thank you all for joining us today. Welcome, everybody. We're really glad you're here. I'm Ranjani, and on behalf of CharmHealth and CharmHealth Square, I'd like to welcome you to today's fireside chat on direct primary care. Direct primary care is a model that many physicians are hearing about right now. Some of you may be actively considering it, others may be early in your exploration, and some of you may simply be curious about what it actually looks like beyond the buzzwords. Today's conversation is really about that, the lived real world experience of DPC. We're very fortunate to be joined by Dr. Jill Dickerson, a pediatrician and the founder of Vibrant Kids Pediatrics, who has personally made the transition from a traditional insurance-based practice to DPC. Jill will be sharing her firsthand journey, why she made the switch, how the transition unfolded, and what has changed since, not just for her practice, but also for her patients and her own well-being. She's joined today by her wonderful husband, Clinton Dickerson, who oversees the practice's billing and administrative operations. Having both of them with us allows us to explore this model both from these critical perspectives of the clinical side and the operational side, which is often where the biggest questions and uncertainties lie. This is intended to be a candid conversational fireside chat. How a lot of what we'll talk about today is how DPC affects workflow, patient relationships, insurance realities, labs, how patients are shepherded through this transition. We'll leave time for questions during the session. Actually, we'll have questions after the session, so please hold your questions, make a note of them. Dr. Dickerson would prefer that we can go back in the slides and address some of those questions that you have during the slides. I also want to highlight that the conversation doesn't end when the webinar ends. For those of you who are physicians on CharmHealth Square, and this is the physician network that we have for prescribing physicians, you please join us on Slack, our Slack community. You're invited to continue that discussion on Slack. You would have received a notification regarding that already. If you have not, please email us at community@charmhealthsquare.com. Or if you're having trouble getting to CharmHealth Square, please email us at community@charmhealthsquare.com. And we'll be discussing this in the channel Masterclass DPC Dr. Dickerson. And you can engage directly with Dr. Dickerson, and Clinton will also be there to answer some of your operational questions as well. And we plan to have this going on for the next until the following Friday. So you can keep your conversations. Does that work for you, Dr. Jill? It's on and off conversation. We can
Yeah, I mean,
discuss.
we can check it. Yes.
Yeah, sure. No worries. And then we can update you, our audience members, as for how long we'll be doing this for. Um, with that, let's go ahead and begin.
Awesome. Awesome. Well, thank you for having us. And it's our pleasure to tell a story of our practice and our journey. I've been a pediatrician for 28 years in private practice. Clinton is a computer engineer, software engineer, now business manager, accountant, whatever else, everything else that needs to happen in our practice. So um, we're going to go ahead and get started and talking to you about a little bit about DPC. So the biggest things are, what is it? It is direct primary care, and primary care is very important. It's not necessarily for specialists that deal a lot with hospitals. It is a membership model, payment model, and it's access. I think that's the biggest thing to get across to your patients. It's a contract between you and your patient for access to your clinic. And what that entails actually is going to be very specific to the type of practice that you're running. For us, we are pediatrics, so that is different than an adult primary care practice would look like. And one of the reasons, and everyone probably knows how restrictive insurance has become of trying to get our patients healthy and keep them healthy. And this is a way to have more freedom with your patient and with that team model to get healthy and stay healthy and make the right choices for that patient of one and not the masses. It is a relationship. I think that's one of the nicer parts is some time, and the trust, because you have more than 10 minutes should you choose to use it. And I think that's, you're not getting incentives. The patients know that you're not getting incentives to push a drug or to give a shot. That has all been removed. It's just between you and your patient. And I think that's the families that understand it when they get this simple thing that we make too complex, love it. That's, I think, been our experiences. They love it. And they never, ever want to leave. And they're always looking for adults that are doing the same thing. And so anything you would add to that one? So misconceptions, what I hear a lot is more that direct primary care or DPC is used interchangeably with concierge, and it is not concierge. I am not bartered and going to houses and, I'm just not a slave to my patients. We feel like it sometimes, I'm sure, but that's not what this is. That isn't when we're not open, we open for a patient. This is a membership. And when our clinic is open, you have access. I think that's been the hardest thing because just out in the press, these terms are used interchangeably. So if you are starting this journey, make sure you make that very, very clear with your families. And again, every practice, every size is different with what they're going to do there, but it is not a concierge. It's not a you're coming to my house at 3 o'clock in the morning because I want you to kind of thing. Other, I don't know. I'm trying to think of other misconceptions. That's just usually the most encompassing one is it gets thrown back at us at times. How does it shift your workflow? Well, we are a pediatric practice. We refer to specialists. So we already had an EHR templated and customized to our practice. So in that sense, we chose not to, as our practice, change how our notes were written, change the workflow in general of how patients are worked up, anything like that. What it did change was how much time we have with them because we have a smaller patient base. So we were able to expand out our sick visits and our well visits. So we have more time to be with the families and to make sure we're getting all the questions and all of those things answered, which is a more sustainable pace. It most days allows for more charting during, it's winter. So most days it allows for more charting and more follow-up, the nurses following up. And it's more sustainable. I think we've all felt that we just can't run anymore. The other thing that we've enjoyed, and we know through COVID, videos, remote access was actually allowed by insurance, but if needed, if someone calls, I can call them back or do a quick video. They can show me a rash and we're done. So you're getting paid for that too. You're not having to bring them into office for every single thing, which then hopefully keeps them healthier and it keeps your office flow better. And it's more convenient for our patients. Our patients we have quite a few locally, but we also have several that live over an hour away, just because the nature of our practice. So being able to do some of these remote lab reviews, so much easier on a video. because then you can get everything typed in and shared, and it's more comfortable. And from a billing standpoint, you can address that. I don't deal with that side.
There's no longer any after the fact billing. I mean, you pay your membership fees and you have the access. So that cuts out a huge amount of overhead and difficulty. Of course, then you have none of the overhead of billing to third parties. So
And
greatly simplifies
the
that.
lag for that.
So,
For our clinic, we actually have, again, we are pediatrics, so there are some point of care tests that we've included. We do a lot of strep tests, we do a lot of flu tests, RSV, urines. That is all part of that's included in your membership. We did not include higher priced items that not all of our patients wanted. And Bicillin was one because it is incredibly expensive.
injection, vaccine.
And vaccines, because not all families want those. And it wasn't, in our minds, fair for all families to pay for something that they're not actually going to use. So we do have families that do want them, and we work with them about the pricing, or if it doesn't make sense for us to buy 10 of something that one person wants, and we can get it in another clinic, then we help direct them to that. But it is a much nicer pace.
Yeah.
Oh, sorry, go ahead.
It's a better pace driven because of the smaller patient base required.
Right. And for the same, to stay solvent, and so some of the things before you transitioned, are you just starting out? How big is your patient base already? We had been in practice for a while,
9 years.
9 years before we switched over. How loyal is your patient base? How do you have something that some other primary cares don't offer? Some medical freedom already that you already have, and we have a full, more functional practice. And so we already had a lot of families that were looking for something different than a hospital-based practice. And so then it's the education to try to see how many that you need to cover your bills and to be, what do you call it? Neutral.
Revenue neutral.
So you're going to need fewer patients to do that, because you're not billing third party. And but are you going to have enough? And people move and transition, and finances change, and so making sure that you've got enough buffer that it still makes sense. Let's see, the number of patients manageable. We said that. And then staff wise, again, usually you are able to have less than you think.
Yeah.
We have than we probably needed, but we were focusing on we have some extra things in our office, some extra treatments that we do. So we needed staff for that. And also for follow-up. So we were erring on the side of better follow-up customer service, and then we're trying to settle that down. If you're just getting started, then if you have a front person that also is your MA or LPN or nurse, that is doing both, then you're splitting who's following up and how that goes. But you don't have to have a whole billing team to take care of that, which is nice that you're not paying non-providers this whole team. You're not having to pay for that. So that balances out for us. It helped balance out some of the extra staff we have for clinical staff. And then insurance is a fun beast. The HSA, that is a question we've had from several of our own families. It is incredibly insurance dependent. And I think we've had one family be able to do that. But usually we say you probably aren't going to be able to do that.
That's the use of those types of accounts are driven around paying fee for service types of visits, and they don't cover membership or concierge fees, which is what the membership fees are considered as. And
Right now. And
most of them, yeah, a lot of legal changes need to take place to make that happen.
I think some states, from what you were reading, some states are progressing.
Some states are more friendly than others. You have to know your state.
Right. Just and that is a big, you've got to know the rules that you have to work under to make sure that it's feasible.
In general, no, the HRAs, HSAs can't be used.
Right. Now with labs, imaging specialists, we run that exactly like we would if we were doing insurance. We are out of network. I am a Medicaid provider. I now know that there's a non-billing option to that, so highly recommend that because that was a snafu. We have a lot of special kids with special needs, and we are the ones ordering their therapy, and so some insurances, the out-of-network cost is more, especially for labs. But if you go to, say, a LabCorp request to their facility, even if you're an out-of-network provider ordering it, you're at an in-network facility, that usually negates it. We also have contracts for cash pay for labs for some of our families that don't have insurance or have really high deductibles. And that's where we have the order and they pay us for what we've drawn, and then we end up paying the bill. That we're very cautious with that. We get payment at time of service with that. I highly don't let that one sit because it will get ignored. But imaging, the specialist referrals, those go through just like they did before. So usually out of network is not as big of a deal, other than maybe your
it's the government plan.
Right, TRICARE, it's a big deal. Medicaid, you have to have a number. So I do not know about Medicare because we're a pediatric practice, so I can't speak to that. But everything else in our clinic other than the billing runs as is. And we kept it that way intentionally because we do so many referrals because of our types of patient base. And then how do we get people to understand? We have been programmed that, well, they've made it as difficult as they can so nobody knows what's going on. This is not. And it's so simple that it's hard for us to back up and understand that, oh, you mean it's an appointment-based, our clinic is appointment-based, not walk-in, but I just have access. And if I need to get a strep swab and I just want the swab, I can do a nurse visit or I can do a provider visit, or, hey, I need to talk about labs and we can do a video visit. And it's all basically prepaid. And our under 2 set has a lot more visits. They're sicker in general and they have a lot more well visits. So their monthly fee is different than our over 2 set. But that's where, just when you figure out and look through your historic data, you can see, well, how many times is this age group usually sick? How many well visits? Well, for adults, it's 1, so there's things like that you can then get an idea of how much you need, how much your services were actually accessed during a year for a particular age group and what that monthly fee needs to be fair and affordable. And then we had mentioned just a variety of media. We have figured out that our patients don't read, even though it is spelled out on the website and it's spelled out on the handout that they signed and it's spelled out and we've talked to you. And so you're going to need to repeat things several times. And, oh, well, I didn't read that. That must have been in the fine print. No, it was 2 pages of big print. But again, once the families get it, then they love it. And then we've got families that are adding new members, new babies, and they're like, when can we get them signed up? When do we get them? How do we? They are so excited to be able to stay within this model. What other thoughts of just the transitions?
Yeah, I mean, it's like they had said, it was just that DPC is very simple once people understand it. But, we're so programmed to think it's complicated that people overthink it. But so it just requires a lot of just communicating.
And if you do
over,
a blog or you do a web blast, or, just depending on how you communicate with your patients, whatever EHR type thing you're using, repetition is good. Repetition is especially the reason that you're doing it. Well, we wanted freedom to be able to treat patients without our local hospital staring down our, breathing heavy down our necks and going, you're giving this, this, and this, when that's not the correct treatment for that particular patient. Maybe fine for somebody else, but not that one. And realizing that that's why we got into medicine in the first place, we're taking that back.
It's restoring that doctor-patient relationship. It's getting
Right.
everybody else out of it and leaving it between you and your doctor directly.
Right. And we still write plenty of prescriptions. All of that is still the same. Even out of network, we haven't had issue with prescriptions getting covered with private insurance. That does not seem to be problematic. So yeah, I love it. I wish we'd known about it sooner. But I think there is a big awakening to this, especially since 2020. People are looking for something different. And if you have that niche, this is going to be a way to have a better lifestyle, because the lifestyle that we have chosen is a lifestyle of service, and there's a lot of after hours, and we know that, and we're committed to that. But if we can find a little more balance, then it just makes everything better, because then you have time to read and research for that complicated patient or take on a more complicated patient that otherwise you don't have time in your day. If you're given 10 minutes to get through something, you can't address an environmental issue or a dietary issue or something. You've got to give a prescription and go. And DPC gives you more freedom to actually dive into your patient, the whole patient, and treat the whole patient, which is what we love about it. And then the challenges, like I had mentioned, that our workflow routine has stayed pretty much the same. The timing, we get 30 minutes for well visits instead of 20, and 15 minutes for sick visits instead of 5 or 10, depending on what your insurance will pay you for. The education, again, you may have more time to do those classes and do the nutrition classes because you're not having to see 50 patients a day to cover your clinic costs.
The challenge is getting your patients to understand the value of what you're doing.
Right. Having value in your time.
Practice and in everything. We're so conditioned to think that healthcare is, an entitlement that we shouldn't have to pay out of pocket for. So it's something, it's that mindset shift again to understand what you're getting.
Right. Well, and we hear a lot of, I pay for that. And then our practice, we did stage it, and I would just go all in if I had to do it all over again. But it's hard with an established practice if you're not sure, because we were the only pediatric practice in the East that we knew that we could find trying out DPC. So we wanted to make sure that we could stay solvent. But everybody pays the membership fee. So we kind of have to re-emphasize that to some of our families and you were paying for insurance out the nose and not getting a thing. They're just denying you care, or it's 3 months before you can get in to see somebody, or you just have to go to the urgent care and you're paying for all of that, or you can only get the generic medicine, which you're paying for all of that as well. So this model at least lets patients get to the higher deductible plan because their day-to-day stuff is more taken care of, if they choose to. And again, the education, we've talked about that. Follow-up is nice. If you have somebody like we've had to this week, we're sending them to the hospital for more imaging and things like that. Well, we can follow up through text. We can follow up through the port, through messages. You have more of that time to ask your staff or yourself to be able to follow up, and then they know that you were looking and they know that you were concerned about them, and it just builds that trust again, and that team. I think that's such a blessing when your families know that you're on their side, and you're trying to work in a team. Maintaining the membership, I think that's more you.
That's the challenge is, making sure you're going to have to communicate, advertise, really helping to maintain your membership. You're not having third parties, payers, shoveling patients your way. So
Right.
You're going to have to continue to educate and advertise to help maintain, keep a consistent membership level.
Right. And we were blessed that we already had a very large patient base that we were trying to cut down. And we are very blessed to have a wait list, which is overwhelming because we have more patients than we're supposed to. How many did you figure?
We're about 20% over our initial number that we thought we would, over what we need.
Right.
So, yeah, that's.
So you can be as busy as you want, but you're doing this for a reason, to have time with your patients. So there's that balance as well. And so yeah, I think that that is so we can stop sharing, I guess, that. And so I don't know if you want to ask the questions we answer, or if you want to go to the so somebody had, I'm going to look at these. How many patients do you need in your practice at your current membership rates?
You have to figure that out.
Yeah, that again, it's very specific to what you do. If you're a psychologist, that's going to be different than a family practice person. And I'll make sure my volume's up. If you look at because you looked at the historic data and number of visits, and that's how we set our monthly fee. But it's
got to start with knowing what your monthly expenses are, and then going from there is like, well, how many patients do you want to have in your practice? And then you start working the math, determining, what that means in terms of a monthly payment per patient, and is that going to be enough, and adjusting from there. But it's all very dependent upon what type of practice, how busy, how many patients, what your expenses are,
and so
and then what what you feel your patients can afford.
And for us,
there's a attendee here who on the same topic here, who's asking sort of the same question. I'm going to just allow them to talk if that's okay.
Yeah, no, that's fine. But I think for us, we had figured out per provider, how much was it, 500? Or
Well, I mean, within the DPC, they kind of indicate it's usually between 500 and 600 patients per provider.
right, just kind of as a
As a rule of thumb.
yeah. Yeah. So if you had 3,000, you're going to be cutting down a lot. And if you are starting out, then you're trying to get to that 500 to 600, which keeps you busy enough per provider. But again, your pricing then has to reflect your community and what you do. And like I said, we chose not to include some of the more expensive things. So our monthly fees were more reasonable. If we have families, is it over 4?
That's all there is.
Yeah, it's, you can, if you pay the whole year, then there's a little discount. There's things like that you can do. And there are some resources and some learning resources out there that we actually, well, I can't say we, Clinton actually used and directed our practice so amazingly into this different world. And it's really nice when you don't have that 4% that you're losing to get your money from an insurer that doesn't want to pay you anyway and is downgrading stuff. So let's see.
So there was somebody wanting to ask a question.
Yeah, I don't know. They didn't reply.
Okay.
So we can go on to the next question. Oh, I don't have any volume, somebody's saying so. Okay. How many? So we're done with that question. What if you're just getting started and it was just you as a solo provider due to PCs do home visits?
I would not.
But I mean, again, that's depending on what type of practice you want to create. If that's what you want to do, go for
it. If you want that is a little more concierge-like. But if you're doing that, then the price per visit, or that's you've got travels, and so it depends on what you're doing. If you are a midwife, then that's a whole different ballgame because you have a much smaller patient base at a time that you can handle. And so, but in our case, with a pediatric practice that needs sick and well visits, I need to be in the office where I've got the tests and stuff like that. And we do labs, and that is just, it wasn't feasible. But this is freedom. This is, if you want to set it up that way, you can. It's just you have to know what your break-even point is, and is that feasible time-wise and lifestyle-wise? Because if you're running around on the road 8 hours a day, that's not freedom either, versus having a brick and mortar, which has its own costs, but it does have some upsides there too. And the Medicaid, our patients pay the membership fee.
I mean, the question.
Let's go ahead and ask the question if that's okay. How are you a Medicaid provider with DPC? Are you also a Medicaid provider? I thought you had to opt out in order to do DPC.
Yeah, we're not a Medicaid provider. We do not take Medicaid insurance. You have to maintain your Medicaid enrollment in order to be a prescribing physician to Medicaid patients who are using their Medicaid outside of our office. So
and we just found out we're in Georgia. Georgia Medicaid now has a non-billing provider that can still do prescriptions option, which they did not have when we started our practice. I did not know that even existed. So that is an option. If you are new to Medicaid, I would get the non-billing. It's office provider referral. I think OPR is what they called it here. But you don't have to send Medicaid claims from your office. But then everybody you refer, like speech therapy, those kinds of things, prescriptions, that all runs fine. So yeah.
I just ask Alex Bowler to see if he can speak now because he came back and raised his hand again. Let's see.
Oh,
Yes.
hi, good
Hi.
afternoon. Sorry, I
Yeah.
think I was muted and then unmuted. I was trying to ask a couple questions, but it's great to hear you both. I'm up in Tennessee, East Tennessee, so I'm not too far from
Fantastic.
you, I guess.
I'm from
And
Easton. Bless you.
okay, so two questions. I don't know how many people are on this call, so I don't want to hog up too much time, but do you stock vaccines in your office, or do you send patients out to the health department or somewhere else?
We have vaccines in office.
We have a pricing for those, that should patients want them, then it covers our cost plus, the supplies and things. So just a little buffer there, but it's pretty much our cost. I can say our patient base is using that less and less. I'll just say it that way. And so, which I'm fine with. We have spoken to, because they can't use their insurance with us. They have to pay us cash. So I would much rather, if someone wants the chickenpox shot or the Prevnar that is over $200 and their insurance would cover it, is like, why are we not going and just at least using the insurance for that? If you have to have it, then let's go get it where you can get it covered. HIB is $40. So we have some families that would choose just to not go somewhere else or DTaP if they wanted it. But especially the last couple of years, that has not been in as much demand. So if you have other options, you can, refer to those other options as well. Many folks like that.
Okay, thanks.
Yes, sir.
Okay,
You said
so
did you have another question?
I did, yes. So as far as do you have to be enrolled with Blue Cross Blue Shield in order to send people to a specialist? Because that's one argument that I'm looking to switch over, but that's an argument people have given me that.
No,
No, because we're out of network now.
we're out of network with all third-party commercial payers.
And so,
She's a licensed physician in the state, so she can write referrals.
right.
Okay, so I could send a referral and it would be covered.
I mean, the pricing the patient may pay, it could affect because, you're dealing with an out-of-network, but if they're going to a facility that's in their network, then that should be covered at the network.
Yeah.
Again, that's all dependent on what their specific policy parameters are.
I mean, because we haven't seen issues with going to the cardiologist or the eye doctor, ophthalmology or any of that. If a referral is required, we're not getting kickback other than Medicaid or TRICARE.
That's why you had to maintain your Medicaid
Yeah, you have to
enrollment
maintain
as a physician in that program in order to prescribe.
But you don't have to get the non-billing option, is what I would say. And we're working on that for our office now, that we know
Okay.
that that's an option.
Thank you.
Yes, sir.
all right, so I'm going to move on to Christy Riniger. I'm sorry, we're done with this one. We'll move on to Anissa Bushetter, who has a question that says, it looks like you use a combination of Hint software and then Charm EHR. Can you share how you use both of these and how they work together? Do you use Hint for EMR? And I just would like to add that one of the reasons we're doing this webinar is CharmHealth is looking to get this added into their work such that it's in the provider's workflow. And so one of the reasons we're doing this webinar is to kind of understand a little bit more about it ourselves and see what the needs are of our practices. And so with that, I'm going to go ahead and pass this on to Dr. Jill.
Okay.
Well,
Yeah, Hint is when
we started.
Hint brought on an EHR just only recently, and for us it was too immature for us to use, based on where we were with our use of the Charm EHR. Hint we use exclusively for managing the membership enrollments. That allows the patients to enroll in our program, select the membership that they want to be a part of, and set up all of their automated billing. And so the Hint platform handles all of your month-to-month credit card charging, does all the dunning and everything to keep the payments coming in. The main thing as far as integrating it with Charm is just making sure that we have flags and notes on the patients' Charm demographics to know whether or not, they are current on their memberships, and then being able to flag them as active or inactive based on their payment status, which is a lot of manual work, and it's something we would certainly welcome more support from Charm on that.
And part of it, again, from our standpoint, is we've used Charm for a long time. And so have our templates very well set. So I can send notes to the endocrinologist or the cardiologist, and it's still set up in that SOAP note format that hospitalists are used to looking at. There's again, I can get overloaded with just things looking different myself. And so we document all the diagnosis codes, everything is there. So if I have to prove anything to an insurance company, my notes look like I'm billing to an insurance company, because it's just as easy to write strep note now as it was when we were billing insurance. I just get paid better. And so the EHR, when Hint brought that on, I was like, oh, well, that's exciting. And it was more free text and not template based. And if you were starting, maybe that helps you. But we'd spent too many man hours getting our templates done. It's like, I don't have the additional time with our patient load to do that. So, and yes, we would love for them to either talk more or Charm to just take it end to end. But, everybody has different needs for your specific clinic. And so you might have to pull more than one thing. That's what we have loved about Charm just in general, is if we have an issue, if we have an idea, unlike Epic, if any of y'all have been anywhere close to Epic, it is an epic pain in the backside to work with. So it's nice to have something that even if they don't have the service, you can usually figure out a way to make it work. Like we have flags, we have things that we know that this patient has the red triangle and they're active, and so it gives us those clues of if there's a problem, we need to look over on the Hint side. And that's part of what he does every day, is membership maintenance things, versus billing insurance. I mean, so you're kind of trading some things off, but it's a little easier in general. I hope that helps.
I'm sorry. What percentage of your practice have chronic conditions like diabetes? Do you currently provide diabetes education services?
We don't have a big diabetes practice. We have a big consult PANS PANDAS autism side in our practice. And so we do a lot of specialized treatments for those. But what's so nice about this is you would have the ability to do online Zoom classes and nutrition classes and education, and that membership fee would cover your time to be able to get your patients healthier. And if there's an additional treatment, like we have hyperbaric, we have some other IVs that you can do. So if there's other things, well, then that's an additional treatment, because not everybody in our practice space is using that. Our consult fee is different because it's an hour and a half with me. That's different than a strep sick visit. So again, that's the customizable part, but you have to know what your practice, what your dream is, and then how can we make the DPC, how many patients do we need? But the education piece would be great. you would probably have more patients, diabetes patients flocking to you if you can get them well and keep them well and keep them out of the hospital, those types of things.
Great. We have numerous questions here, and what is your time constraint? I was thinking I'll take just a few more questions before, and if some of you are on Charm Health Square, that would be a great place to like continue this conversation. So what is your time constraint?
Referrals, the med refills, I mean, Charm, I mean, I send medicines through Charm. Boom. It's there is no difference in that. There's zero difference. This is just a billing for your practice, which is nice. Patients can pay monthly or annually. There's a discount for annual. There is paperwork, but Hint does a lot of that.
And the paperwork initially is reviewing and accepting your membership contract.
Right.
But
Right.
then after that, it's just, your normal intakes that you would use for any in-office visit or
Right.
encounters.
You're just history. So again, it's taking what you're already doing, and we're just adding this little piece over here, but it's very freeing, very, very freeing.
You spend money on marketing to maintain the patient population and attract new patients?
We
haven't had to.
We've had enough organic word of mouth, to not have to
Yeah.
deal with it. I mean, we maintain just basic costs for maintaining the website, but
I think,
I mean,
yeah,
we have an extensive wait list already, so it's not to our advantage to do a lot of advertising at this point.
and so I think, yes, I'm on call.
Are you available to patients 24/7 by phone and email?
I mean, but every doctor is. See, that's the thing. Now, I don't know about adult doctors because I know that there's lots of referrals around this area. If you're sick after hours, you just go to urgent care, and you don't get a call back for 3 days. That's not how pediatrics works. I've always been on call 24/7. So that doesn't change. How I'm contacted, we use the texting, which is nice, because it can connect to my phone. But we do work with our families to know, look, medication refills are not an 11 o'clock at night phone call for some non-emergent thing. That's part of your education of your patient. Is we have a patient portal that send me messages there. I'm on the computer, unfortunately, almost every day. I can see that. That's where medication refill should be, requests, and Charm does that. You just, pharmacies do that. But after hours is urgent needs, just like it would be in any primary care practice. You have an urgent need, you need to talk to somebody that it can't wait till morning, yes. But again, that's how you're setting up your practice. But I'm in pediatrics. If somebody has croup at 3 o'clock in the morning, they text me, it buzzes my phone, and I call them back. So it's not different from that type of workflow. I will say the texting is nicer because it's a little easier to text and go back to sleep on some things than to talk to somebody on the phone. But that's, I can click the text and it calls. I can call through my computer, with Charm now has a little phone icon, so I can call through the computer to patients if there's an acute need or whatever they've texted me just isn't making sense and I really need to hear the cough. Okay. So I'm rambling, sorry.
I'm going to go to this question here. I'm trying to think about how to get started. How much is an upfront cost to get started? What would you imagine? Having to pay rent for an office seems daunting before having 500 to 600 patients enrolled in the practice.
Well, I think that's different if you already have an established practice because you already have some buffer versus getting things. I mean, it's a business loan just like everything else because you're gonna have, it takes what, 3 months to get paid by all the insurers too. So, anytime you're starting a medical practice, you're going to have a delay in reimbursement. There's less delay with this, and there's more monthly stability with this, which is nice. But again, it's how big do we go? If you're a single provider, you don't need 6 rooms. So you don't need a huge space, a huge overhead to start, and a huge staff overhead to start. You can grow into that. But yeah, I think you're going to have a medical business loan anyway. And so that's just what you kind of factor in. And the question of Medicaid, we have a Medicaid number. Our patients are choosing not to use their Medicaid to see us because we offer them specific services that their Medicaid will not pay for. And that's, they're not forced to see us. They can see anybody in the community. They choose to see us and pay a monthly fee because they like what we are offering. Their Medicaid gets used for everything else, any send out labs, anything else outside of our actual clinic visits and buildings.
And services rendered by us under the DPC contract are not reimbursable by any insurer, Medicaid included.
Yeah.
If you're using your insurance, you're using it for services that you're receiving outside of our office.
And so that we don't do super bills for that. I mean, I know some people do, but we have chosen not to because it's simpler and it's all included in the membership. So other than the vaccines, there would be a bill for that. So I guess they could do that because they're paying us. But yeah, we don't in general don't.
And then do most of your patients use credit cards or ACH transfers? How do you keep track of making sure payment methods are up to date?
Maintaining the patient method, that is why we use Hint Health's platform. And it's I don't know, it's a mix of credit cards or ACH. I mean, I'm not sure the exact breakdown, but I mean, they use both. The platform tries to encourage people to use ACH transfers because there are lower fees on that. But that's what we have Hint for.
And they send out reminders, and then then he gets notices if something is past due, so many payments. But and then it gets a little more. We've had to be a little more like your membership's canceled. So, and it's like, we didn't see any emails. Oh yeah, they did. But it kind of brings them back. It's like, please pay attention to this. It was in the fine print of the 2 pages that you signed. And so, but that's where Hint does have that system down pretty well. And hopefully that's something that with y'all's interest, Charm can continue to integrate either with Hint or their own model.
In the experience at Serbo versus Charm, a lot of functional folks are using Serbo.
Yeah, no experience there.
I'm not sure. Sorry. What I learned about Charm through my training in the MAPS program and basically have known of them since before they even had growth charts because they were just for consultative work. So it's completely blank slate, build your templates, how you practice your niche of medicine. And now they keep adding in more of that primary care piece and these other models. And it's been great. It's been great to actually be able to have ideas and say, this is really what we need. And this makes more sense because engineers don't always have the medical side. And luckily Clinton is a software engineer and knows a lot of things, and he has been able to offer some very practical tips on what was going on early on as Charm was growing. So let's see.
We'll just try to wrap up here by 1 o'clock, if possible. Can you talk more about the consultation visits mentioned in your website fit with the DPC model?
So we have some families that live a state or two away. That doesn't make sense for us to be the primary care person. But if they live close enough, then we are also their primary care. So they get a well visit, they get 4 visits a year. Only one of them has to be in person because they're usually traveling with a child with special needs is challenging. And so, and many of them, there's even more, but that one is a higher monthly fee because of the time that I spend on labs, and the initial visit's an hour and a half. And so the model, again, it's the cards on file, and it makes more sense to me to pay what an initial consult would have cost over a year and get 4 visits. I mean, it sounds like a better plan, and it's better continuity of care. It seems to do better with follow-up because they're like, oh yeah, we get quarterly visits now, versus have I saved up enough that I can pay this $300 or $400 and talk to her. So it is helping us follow our patients a lot easier, and budgetarily is making it a little easier for these families to do that. I hope that answered that question. And some folks still do fee for service for that, but there's cards still on file, so it's not as hard as you think it's going to be.
I know Charm has the option for recurrent billing now. Do you know if there are features that Charm is still lacking in order to move that piece over from Hint to Charm?
Yeah, I've been watching that for a while. I think a lot of the patient communication involved with that is just really not mature and professional enough compared to how Hint system does it. And then with the different fact that we have managing that membership contracts, we have things like age breakdowns. As we mentioned, 2 and under is a different pay rate than 2 and above. The Hint system already handles all of those transitions and changes the pricing and all for you, and that would all become manual work within the Charm platform if we were going to use that. But it's certainly something that we've been following just kind of to see if it reaches a point where we think it can do it for us.
It's getting closer.
Yeah.
Do you contract with hospitalists if patients need to be admitted to a local hospital?
No, because our local hospitals, our children's hospital, if you're not part of their staff, you can't admit anyway. So the hospitals around here, if you're not part of their paid staff, you don't have admission privileges. So we have I'm affiliated with the Children's Hospital, but I'm not under any of their rules and regs, which is nice. So I can send people there, but it would just be like a family practice or an urgent care sending there. I can log in and see what's going on, and I can order labs, but I'm not directing their care while they're in the hospital. So again, that's very community specific and state specific and specialty specific.
So we'll just take this last question. Is it allowable to do virtual visits across state lines? I'd love to do that, but only have a medical license in my own state.
Yes. Yes. I have patients in Florida, Alabama, Tennessee, Virginia, California. Yes. Because I'm a licensed physician, and if my patients travel, I can prescribe a medicine to a pharmacy out there. So why can I not do some medical care? So I'm not sure if you're stationed in another state, but it shouldn't from a medical doctor standpoint, that should not be an issue. I know naturopaths in this state, it's a little different. So there are some nuances there, but from a medical doctor, no. Your patients can be anywhere. Because they travel. And so I just think of it as you're traveling and you're in a different state. Okay. Why? I'm telling you the same exact thing on the video that if we were talking on the phone or you were in the office. So, but that's the nice part about DPC. You're not having to justify to an insurer that you're actually doing good work. Your patient is the primary focus. So I think I answered. Yeah, we've got patients everywhere. Other thoughts? Or I hope this was helpful from a pediatric standpoint. Folks may not be peds, but go peds. They're fun. And in terms of the self-sign up for automated billing. Yeah, so that's I don't know what DSC. I don't know what that means. Yes, I'm licensed in Georgia, but as a Georgia license, I can prescribe in other states. Now, I'm not practicing in that state, but I can take care of patients in other states. So that's not been an issue with in the MAPS provider window. So yeah, I think again, you have a membership contract. So you have an understanding with your patient as well. And they're not using insurance, so it takes that direct specialty care. I'm not familiar with direct specialty care. I know, that would probably be dealing with more hospitals, and that gets stickier because of all of those rules. But awesome. Let's see. Well, thank you all for your time. I hope you have a great afternoon. Depending on what coast you're on and where you're at, you're either getting started with your afternoon or you're finishing up. And so I will get on the community site probably tomorrow. Tomorrow's a consult day, so I have to get ready for that. So and then if you have any other questions, just let us know.
Wonderful. Yeah, a wonderful session today. A lot of great participation from our attendees, and thank you so much for taking the time to answer them so patiently. Yes, and we have people who have requested to connect with you on Slack at CharmHealth Square. So please, all of you if you have more questions, or your fellow physicians who are prescribing physicians, if they have questions, they are welcome to join that channel and connect to Dr. Dickerson and Clinton as well. He can answer your questions. So thank you again to everyone who joined us today and contributing your time and attention. I truly appreciate it. Again, go to Slack that is Masterclass DPC Dr. Dickerson. That's what you'll find. That's specifically a channel meant for DPC conversation. And thank you all again.